Marco Maloney. Can you hear me, Marco? Hello, Dr. Osduman.
Hello, Dr. Bennett. How are you?
Very good. Let me unpin myself here so I can see you. Everything going well in Istanbul?
Yes, but you don't sound well.
No, I am well.
With the cough? You're doing well?
Yeah. I feel great.
Glad to hear that. Glad to hear that.
Yeah. Nowadays, it's not a given. It's not, you don't accept good health. I mean, you got to wash yourself.
Exactly. And anything can happen any day.
Yeah, even to doctors, unfortunately. Although I haven't, I know a good number of doctors with COVID, but most of them seem to be handling it pretty good. Knock on wood. Hello, Marco.
Knock on wood.
Hey,
Knock
John,
on wood.
how are you?
Hey, good to see you, Marco.
See me too.
I'd like you to meet Dr. Osduman. He's a presenter today from Turkey. He's a neurosurgeon.
Hello,
Okay, nice
how are you?
Marco,
nice meeting you.
Marco has a specialty in peripheral nerve, and he's going to give a workshop on it
Excellent.
soon.
What's the timing? When is it going to be?
Well, hopefully, I don't know. We're working it out. We're working it out. So.
Yeah. Maybe on the next 2 weeks, I guess. I'm completing my panel, so just 2 weeks, and we can continue with the second part. Is about surgical anatomy of brachial plexus.
Oh, excellent! Very tough topic.
Yeah. I was telling Marco that. I said I haven't seen too many good webinars out there on peripheral nerve injuries in the neurosurgical area. Hopefully, we'll be able to fill that gap in.
I look forward to it.
Yeah, and the panelists Marco's gonna have a peripheral nerve series soon. So if you're on the mailing list, you'll hear about it. We'll keep you up to date with what's going on.
Por lo de la pandemia no están haciendo sonido.
I'm sorry, do you have a question?
1 second, please.
Yeah, sure.
Teşekkür ederim. Sağ ol. Professor Sbey is here.
Hello.
Good evening. How are you?
Good evening. Evening all.
Thank you.
How'd you get in, Dr. Sabea? I didn't click you in.
I sneaked in.
Yeah, I left the back door open.
Through the cavernous sinus.
Exactly.
We got 8 minutes. 8 minutes.
Sure.
A lot of people come at the last minute.
Professor Sbey, how is the situation in Jordan? Are you safe and well?
Yeah, we are all well, thank God. But there is increase in number of the COVID-19. This is a second wave sort of thing, but we are in control.
Same in Istanbul.
How is Professor Pamir?
He's recovered very well. This week he's joining work again.
Good.
Mm-hmm.
And,
5 minutes.
Great. Can you hear me?
Yes, we can hear you.
Corey, what topic should we do next week? I was thinking of Coronial magnum meningioma from the microsurgical point of view and the radiosurgery point of view, or craniopharyngioma from the surgical and radiosurgery point of view. Which one do you prefer?
Whatever you prefer, sir. Like, both are very good topics. Foramen magnum meningiomas, maybe as an adjunct to this week's petroclivals, because they're similar.
Sure. So do you want us to do the craniopharyngioma, and maybe the following week we can do the foramen magnum?
Yes.
So next week we'll do the craniopharyngiomas.
Yes, sir.
Good. That's good. You can hear me, John?
We start in 1 minute.
Sure.
You guys are building a following.
That's good.
Yeah. Radab, she's from Jordan. She's here. I think you probably know her, Dr. Sabea. You're muted there, Dr. Sabea. You're muted, Dr. Sabea. Can you unmute, please?
I said Radab is the first female neurosurgeon in Jordan.
Really? Wow,
yeah.
That's great. Okay, we're going to start. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. Today we have the honor of hosting another webinar for Jordan Neurosurgery Grand Rounds with Abraham Sabea leading. And we have Koray Ozduman, a neurosurgeon from Istanbul, Turkey here also. So I'm going to turn it over to Dr. Sabea. Welcome, Dr. Sabea.
Thank you very much indeed. Right, as always, I start by saying good morning, good afternoon, or good evening, wherever you are. My name is Abraham Sabea. I'm a neurosurgeon from Jordan, and we are transmitting together with my friend and colleague, Professor Ozduman from Turkey. I'm now at the Farah Medical Campus in Amman, Jordan. And we'll be talking about the petroclival meningiomas, which constitute 5% of all intracranial meningiomas, but they are one of the formidable lesions. Look at the relationship with the brainstem and the cranial nerves, and you can imagine the difficulty there. So this is a joint venture between myself and my friend and colleague, Professor Ozduman from Turkey, from Acıbadem Hospital and Medical School. I'll be talking about the surgical part of the petroclival meningiomas, and Professor Ozduman will be talking about the radiosurgery part. Of course, we complement each other because we are not sort of fight between surgery and microsurgery and radiosurgery. They complement each other. Before I start, again, I have always the duty of presenting Jordan to you, my country, my beautiful country. Many people don't think of Jordan as mountainous and as very beautiful, serene areas. Look at this, beautiful areas. In addition to the, of course, the desert. And when I say desert, I mean Wadi Rum, the famous Wadi Rum. It's called moon-like or Mars-like terrain. Beautiful for tourists. It's a very nice destination. And Petra, of course, is the jewel of the crown. And something that you can never see anywhere else in the world is this. To be in Petra or Wadi Rum at night and you'll see stars like you've never seen it before. Never. I'll show you some of the movies that were filmed in Jordan in that particular area because it's very, very famous and very touristic attractive. That was Harrison Ford and Sean Connery in The Lost Ark, was filmed in Jordan, and the very famous Aladdin by Will Smith.
Okay. Sorry, I didn't have the audio on for this.
And this should show you a group of films that were made and filmed in Jordan, and the same locations that I mentioned to you. Tamsara, 2011. Queen of the Desert, 2015. The Martians. As I said, it's much like moon-like terrain. That's why these movies are made there. Mortal Kombat. And the famous of them all is Lawrence of Arabia. We are talking about Anthony Quinn, Peter O'Toole, and Omar Sharif. That was back in 1961 or 62. Jordan has been open for so many decades for the movie industry. This is the famous Anthony Quinn and Peter O'Toole. The Transformers, 2009. The Mummy Returns. Prometheus. And this very beautiful Indian movie. I hope that you have enjoyed these beautiful movies done in Jordan. The relation between Jordan and Turkey is very strong. It's hundreds of years. Jordan was part of the Ottoman Empire for about 400 years. And this Hijaz Railroad started in about 120, 130 years ago. It starts in Istanbul and then goes down to Syria, to Jordan. From Jordan, it goes to Aqaba, and from Aqaba, it will go to Mecca and Medina in the Holy Land. Last time I mentioned the relationship between the Turkish Neurosurgical Society and the Jordanian Neurosurgical Society. I've known a few people like Professor Ejderjil, Kanpolat, and Ozgen. Professor Ejderjil has a very strong relationship with Jordan. He's a family member, really. Professor Kanpolat was with me in the World Federation of Neurosurgical Societies. And Professor Ozgen also was member of the Skull-Base Surgery Committee of the World Federation, and here we are gathering in the Mount Fuji, being invited there by Professor Kawase. Also, Professor Pamir, a member of the Skull-Based Surgery Committee of the World Federation, and myself, here we are in China. Turkey was bidding 2011 to host the 2017 World Federation, and we were part of that campaign. Myself and my wife, we met with Professor Yazdarjil, Professor Amir, and Recep Tayyip Erdogan, the Prime Minister. Here, the very kind of conventions that we attended to support Turkey in its bidding. And that's 2017, when the conference was held in Istanbul. Myself and Professor Pamir are members of the World Academy of Neurosurgical Surgeons, and Professor Pamir became the president of that very prestigious group. And myself and Professor Pamir, we were in Karolinska Institute in Stockholm to train for the gamma knife. That's myself with Professor Pamir, Professor Pamir. And we were in Jordan the first to get this gamma knife in the Middle East in June 1996, I think 6 months before Ankara and Professor Pamir got it. Professor Pamir invited me to his center at Jivadam Hospital. I was really honored to accept the invitation, and met with all my colleagues there, including Professor Osman. And both Pamir and Osman really took good care of me and my family. For this, I thank them very much indeed. I hope good health for Professor Pamir. Back now to the track, to the petroclival meningiomas. Once you mention petroclival meningiomas, you have to mention those people, those giants, those teachers, mentors, who taught us so many things. And first and foremost is the late Albert Rutten, who was like a father figure for me. Professor Sami, also he's a family member of me and my family. Professor Takeshi Kawase, he came to Jordan many times, and we traveled together, and we were part of the World Neurosurgical Society. Professor Vinko Dullens, who worked very hard at the cavernous sinus and the petroclival meningiomas, also visited Jordan many times. He's a family friend. Professor Osama Al-Mifti, long friend for so many years. And Professor Bayam Shaker, also a friend and a colleague who visited Jordan and who contributed a lot to our understanding of the petroclival meningiomas. So, something that I found that people mix the infratentorial meningiomas together. So, all these meningiomas are collectively being labeled as posterior fossa meningiomas, which is wrong, because each and every one of them is a different kettle of fish, different category of lesions. The best classification you can find is by Professor Sami. Infratentorial meningiomas or posterior fossa meningiomas are 4 types: cortical ones, the lateral petrous ones, cerebellopontine ones, and the petroclival ones. So this is cortical. This is from the cortex of the cerebellum here. This is cortical cerebellar. This is arising from the lateral part of the petrous bone, so it's a lateral petrous group. And then comes the cerebellopontine angle. Cerebellopontine angle, here is the internal detritus. They can be grouped like this, either posterior to the meatus, or anterior pre-meatal, post-meatal, or superior or inferior to the meatus. So this is the cerebellopontine angle lesions. So here we are, the internal detritus, the trigeminal nerve. The tumors could be here, which is post-meatal, or here, pre-meatal, or here, superior meatal, or inferior meatal. All these are grouped together as cerebellopontine angle, different completely from the lateral petrous group or the curtain group. Also here is the internal detritus and the trigeminal nerve, the post-meatal, pre-meatal, and then come here, medial to the trigeminal nerve is the petroclival meningiomas. So this is post-meatal. All the tumor is posterior to the meatus. So this is the meatus, and this is a post-meatal, suprameatal, premeatal, and here is the inframeatal. You may find the tumor centered over the internal detritus. So this is the internal detritus. So the tumor is centered around. This is not a petroclival meningioma. This is cerebellopontine angle meningioma. Suprameatal above the meatus here. Inframeatal. All these are grouped as cerebellopontine angle meningiomas. This is premeatal. The petroclival then is a different kettle of fish. These are meningiomas arising from the apical petrous bone, upper 2/3 of the clivus, medial to the trigeminal nerve. So this is internal detritus, this is trigeminal. It's arising here from the apex of the petrous at junction with the clivus. So it has to be medial to the internal detritus and the trigeminal nerve. Here we are medial to the internal detritus, and the trigeminal nerve should be here. So this is typical petroclival meningiomas. And I said they are formidable lesions. So they are arising from the dura medial to the fifth cranial nerve. And that's a very important message because the bulk of the tumor will be in that area, petrous apex, tentorium, clivus, but they can extend everywhere, supratentorial, cavernous sinus, CPA, middle fossa, everywhere. So this is a petroclival, and then extended across the midline like this and like this. So they can extend everywhere. These are MRI of my collections, looking at the extension of these tumors everywhere. They can go into the middle fossa, to the cavernous sinus, across the midline to the other side, and so on. All these are extensions of this petroclival meningiomas. Or they can be totally both sides of the clivus in the midline, and they are called clival meningiomas. Some of the anatomy that we need to know before we deal with the petroclival meningioma, remembering that there is a petroclival angle between the petrous bone and the clivus. This angle is very important, like this. So here we are. This is the trigeminal nerve, this is the abducent, and this is the equimotor nerve. The origin of the petroclival is in here, medial to the trigeminal nerve, on the petrous apex and the clivus. So you have to know the anatomy of that area pretty well before you just think of doing anything there. This is a beautiful paper done by Majid Sami and Pablo Cababianca, taking us to understand the abducent nerve and the relationship of the ligaments there. So this is the trigeminal nerve, underneath is the Gruber ligament. If you remove the trigeminal nerve, you'll find the Gruber ligament, and underneath is the Dorellus canal where the sixth nerve passes. So this beautiful paper also giving us the opportunity to see these people who were our mentors, who actually taught us the anatomy and the names that we are dealing with the Gruber ligament. Of course, the name Dorello, the canal for the sixth nerve. Cardingo is the man who discovered the syndrome where you have the nerves affected in the cavernous sinus, and the man who publicized this around the world is Vail. So if you look here at the back of the clivus and the petrous apex, this is the trigeminal nerve. The tumor will be arising here. So sixth nerve is endangered, third nerve, fourth nerve are in danger, and this anatomy is very important. If you strip the dura, keep the dura here, strip it here, you will see this venous plexus, the basilar venous plexus, and then you will see the abducent nerve passing through that plexus underneath this Gruber ligament, which is the petrous sphenoid ligament, and there is the canal, the Dorellus canal, underneath, so lateral to the carotid artery in the cavernous sinus. There we are. This is magnified view, sixth nerve, underneath the Gruber's ligament, in Dorellus canal, to the lateral to the sixth nerve, to the internal carotid artery. Here again is the sixth nerve going into its Dorellus canal, dural canal there, fifth nerve, the tumor will be here. So you have to know the anatomy very well. And the only way to know the anatomy very well is through cadaveric experience, cadaveric training. So this is the sixth nerve going into underneath the Gruber's ligament, and these are the branches coming from this artery here, the meningiohypophyseal artery, which is very important artery if you are dealing with the petroclavian meningiomas. The meningiohypophyseal artery divides into inferior hypophyseal artery, which goes to supply the pituitary, and then there are branches that goes to the meninges, branches that goes to the clivus, and branches that goes to the tentorium. And of course, the tentorial arteries are either marginal in the margin of the hiatus of the tent or lateral to that. So all these branches are the main blood supply for these meningiomas, and you will face these if you are operating or if you are embolizing these tumors. Again, the meningiohypophyseal artery, and here is the artery of Casanari going into the edge of the tentorium. This is different kind of ligament that's holding the carotid artery in the foramen lacerum. Again, this is top view showing you the meningiohypophyseal artery, the inferior hypophyseal, and the tentorial artery and the clivus arteries, clival branches. As I said, this is different ligament. So this is a Gruber's ligament underneath which passes the sixth nerve. This ligament, which is the petrolingual ligament, holds the carotid artery in the foramen lacerum. Another piece of information that one needs to know, and this was a very beautiful paper published 2013 by Aaron Cohen Gadol from the United States, is the relationship of the superior petrosal sinus with the trigeminal nerve. So it can pass above it, can pass below it, it can branch above and below, and the trigeminal nerve is at the Michel's cave is between these two divisions of the superior petrosal sinus. And we need also to know the anatomy of the superior petrosal vein or vein of Dandy. Is it one branch or multiple branches? And as it goes into the superior petrosal sinus, it's a very important piece of anatomy of how to preserve that vein. Professor Albert Roten published this beautiful paper about the variations of the superior petrosal veins. So this is the superior petrosal sinus. This is the vein of Dandy or superior petrosal vein. So this is one variation. Look at here, superior petrosal vein going to the sinus, which does not exist here. Here it does not exist posteriorly. Here it does not exist in this part. Or it can be in both parts like this, and it drains there. Why do we need to know this? Because whether we are doing the transpetrosal approach or whether we are doing the retrosigmoid approach, if you damage these veins, you will get venous infarction. And this is a famous paper by Osama Mufti speaking about vein of Labey, injury in the petrosal approach, and the venous infarctions that it can cause. Also, we need to know if we are going or attempting this approach to transpetrosal, whether subtemporal, extradural, or intradural, is the relationship between the superficial middle cerebral vein and the other veins in that area. This is called type 1 cavernous because it's going to the cavernous. Here it does not exist. So many variations of these veins. And if you are attempting a subtemporal approach, then this kind of information is essential for you to know exactly how to avoid a venous infarct. What is the natural history of these petroclavian meningiomas? Do they grow all the time? Yes. The natural history suggests progressive growth with the progressive neurological deterioration and death. So natural history is continuous growth. And this is an example. Look at this tumor here, small petroclavian, 2 years enlarged, 4 years more, 5 years, 6 years, and 10 years. Having said that, this paper by Majid Sami, 2003, showing you this tumor and 7 years without any change. So sometimes you may get surprised. And this, the message here is don't jump on any tumor. sometimes you need to wait. And I had this experience with this lady with this tumor, the PETROUS meningioma, back in '98, who was well. We discovered this incidentally, so we waited 2002, 8, 12, 17, and there has been no change whatsoever. She takes one tablet of Tegretol for her mild facial pain, but nothing else. So what's the management of these tumors? Observe, like we said, in these cases, or surgery, or radiotherapy or radiosurgery. When do we observe? If the tumor is small, asymptomatic, like this lady I presented, it was discovered incidentally, or if the patient is medically unstable and you want to give him the chance to recover. What about surgery? This is a statement which is very important to all of us. Microsurgery alone may be sufficient. In certain cases, radiosurgery alone is sufficient, but in significant group, combination of both. So microsurgery complement radiosurgery, radiosurgery complement microsurgery. There's no fight between the two, but it is the good judgment of when to use this and when to use that. If you are not a good surgeon, everything will be treated by radiation. If you are just radiation, you will not even think of surgery. It's a combination of both. These tumors were considered inoperable up to 1970. And look at this by Sami. Retroclival meningiomas are one of the most formidable lesions in skull-based surgery. And that's what exactly Professor Al-Mufti would say. Anil Nandam, my friend from Louisiana, he says this back in 2007. I'm personally convinced that retroclival meningiomas still hang like an albatross around our neck. They are really difficult ones. However, surgical resection continues to be the first and best treatment. And the treatment goal here should be complete resection, which is the only potentially curative option, as said by Majid Sami. However, complete surgical removal, although it is the optimal treatment, it should not be achieved at the expense of the patient's life and quality of life. So when you go in, you are going in to kill the tumor, to take it radically, completely out. But then you discover during surgery that you can't accept defeat and come out leaving the part of the tumor in. But if you decide before you go into surgery that I'm going to take a piece and then give radiotherapy or radiosurgery, this is wrong. This paper from Germany by Johann Stramm, who has been the president of the European Society of Neurosurgery, retroclival meningiomas, is radical resection always the best option? And the answer from this paper, yes. But there are certain subset of tumors like this here, the cavernous sinus, where you leave part of the tumor. If you look at across the publications, gross total resection, which is the gross total means Simpson grade 1 and 2, is reported in 50% of 1,000 patients reported in 19 studies published. So we speak gross total, which is Simpson grade 1 and 2, near total Simpson grade 3 and 4, and subtotal Simpson grade 5. So you have either the cohort total, or if you can't, you do subtotal with radiation or radiosurgery. The primary goal before surgery should not be subtotal excision. So it is your state of mind. You are going to surgery saying to yourself that I'm going to take a piece of the tumor and then the rest I'm going to give radiation is wrong. This will lead to inappropriate surgery by inexperienced surgeons, and this will cause significant morbidity, and the brainstem compression would continue. This is what Majid Sami would tell you. So an approach that starts with the idea of subtotal resection does not serve the patient well regarding the chances of complete excision. I hope that I made this message clear. It is the state of mind when you go in that you are going to take the tumor out, gross total resection. You may be able, you may be not. Don't take risks on the patient's expense, but don't again think of just taking a piece of the tumor and give radiation. This is also extremely wrong, like in this case. So partial removal and gamma knife, some people just plan it like this, and to me this is not acceptable. I don't subscribe to this way of thinking beforehand up front. The approaches here are variable to reach that area, to the reach to the petroclival area, the retrosigmoid, transpetrosal, translabdentine, transcochlear, middle fossa approaches. Is there any one that we can select to be the best? No, it is impossible to specify one particular approach as the best or the only option. So you cannot be a prisoner of one approach. You have to know all the approaches, but use it in a good way, in a good fashion for each particular case. So you can go orbitozygomatic, you can go terional to reach this area, subtemporal, extradural, intradural, transpetrosal, anterior and posterior, or the retrosigmoid. So again here, we want to reach to this area. This is the way you can reach, as mentioned. Again, you are going to this area here, hidden by this middle peduncle. The same thing, terional, orbitozygomatic, subtemporal, transpetrosal, retrosigmoid, and we can go, especially with the endoscope, transfacial and transoral. There got to be an algorithm for this, and this is one of the algorithms that Osama al-Mifchi suggested back in 2014. Easy. When you do your investigation, you look, are you dealing with a small tumor or large tumor? Is this tumor superior to the internal meatus or above it? So you choose your approach, anterior petrosal, whatever. If the tumor is large, extending across the midline of the clivus, then you can have the combined petrosal. And here you would think of the hearing, is it there or not there? Hearing is lost, you can do total petrosectomy. If the hearing is still there, then you will do posterior petrosal approach. Another algorithm published by Bambakidis from the United States, he became the president of the American Society back in 2013, and again the same applies. Is the tumor in the posterior fossa or it is in the posterior middle fossa? Is it lateral or medial to the internal canal? Should we use retrosigmoid, or should we look at the hearing, and if the patient has useful hearing, what should you do? And no useful hearing, what should you do? Same thing here. So there is an algorithm. There is something that you can look at as a landmark what to do in each particular case. And the approaches that we mentioned, and I adore this approach because it's very good. It is the workhorse of my cases, the retrosigmoid approach, and it is the same thing for Professor Sami. He believes that the petroclival meningiomas are best removed via the simple and safe retrosigmoid approach. And if additional exposure is required, you can drill the petrous apex intradurally. And he published this. This is the promontory above the internal meatus. You can drill, and then you can get into the trigeminal cave, Nicholas cave. From China, this paper about the retrosigmoid approach for these tumors. From Japan, 2011, again, retrosigmoid. You can go laterally, or you can go above the cerebellum, that's the same, depending on the size of the lesion. From the United States, this approach of retrosigmoid approach, again by Al-Mifti 2013, transmastoid retrosigmoid. So you drill the mastoid really well so that you would avoid the retraction like this. From Anil Nanda in the United States, retrosigmoid intradural suprameatal approach like the one described by Professor Sami. And from India, my friend Peter O'Toole published this paper 2004, again using lateral approach retrosigmoid or supracerebellar infratentorial to get to these tumors. Subtemporal approach was described by William Shaker from Seattle back in '92. This in recent paper, subtemporal transtemporal approach. So you go subtemporal intradural, you slit open the tentorium away from where the trochlear nerve passes into the edge of the tent. And then you take this completely out, you can excise it completely, and then you will have access to the tumor there. This paper from China, again, subtemporal, you can see the tent and the way to open the tent. never open it here because this is the fourth nerve going here into the edge of the 10th. So if you open it here, it will damage the nerve. You go posterior and then you open it this way. Anterior transpetrosal, first described by Kawase, that's why it's called Kawase approach, back in 91, sorry. So you get into the Kawase triangle or quadrangle, as one should mention. So this is the arcuate eminence for the semicircular canal, the severe semicircular canal, and the internal detonator should be here, and of course the cochlea is here. So you have to drill this without damaging the internal detonators or cochlea or the petrous carotid artery. Once you do that, you will get into the posterior fossa dura. And meanwhile, you have maintained the integrity of the greater superficial petrosal nerve and the eustachian tube. Again, pictures of the Kawase triangle and how to avoid the internal detonatory canal and the cochlea, the landmarks of the greater superficial petrosal and so on. So this is a case taken out by anterior petrosal. So you see, this is a very good approach for a small, high petroclival meningiomas. And Professor Kawase published this paper 2011 comparing the retrosigmoid with the presigmoid with the anterior transpetrosal and the pre-sigmoid transpetrosal, and he gave a score to that, and he found that his approach to the anterior transpetrosal scored the best, scored 8, better than pre-sigmoid, better than retrosigmoid, and so on. A paper from China is the transpetrosal approach, again, for the same pathology. The pre-sigmoid, I'm going into here, this is a small area here, so that you would open here and get into the tumor. This is from my cadaveric lab, showing this to the residents, the pre-sigmoid approach that is going here. The first who described this was Hakuba and the Professor Al-Mifti, and he called it petrosal expressway, which it really is, because this, you can open this completely, the temporal, the posterior fossa, avoiding the sinus, and then you have the whole area in front of you. Published again 2009, Al-Mifti with William Caldwell, same describing these techniques and the preservation of the petrosal sinus. He can use both anterior and posterior petrosal, and he called it combined petrosal or double petrosal, as he calls it. And this is the approach: anterior petrosal, posterior petrosal, and you have the whole thing in front of you. And in the words of Mufti, would tell you that this petroclival meningioma is changed from a deep lesion into a cortical lesion, as it were. Also described his technique to preserve the superior petrosal sinus, where to open. Again here by Kenji Ohata from Japan, a very good, brilliant skull-based surgeon, showing where to open this between the middle fossa dura and the posterior fossa dura. Siffert from Germany, skull-based surgeon, also described this, the transpetrosal approach, the anterior and posterior. So this is the temporal part, this is the posterior fossa part, and this is the reconstruction after that. Pampakidis also described this technique, retrolabyrinthine. Van Loveren from the States described the predictive parameters. In fact, this paper is a landmark by Khalid Abdelaziz and Van Loveren. Khalid is the assistant of Van Loveren. It's really a very good landmark paper for the how to predict the outcome of these tumors. Still is a landmark paper. And this very nice paper from Japan using interactive pre-surgical simulation. So you see with this machine, and you actually use a virtual retractor, and virtual will know exactly where you are. So this is another method, in addition to the cadaveric lab, to teach you how to do these cases. What about endoscopy? Endoscopy is the future of neurosurgery, I have no doubt about that, but for petroclival meningioma, still in its infancy. This is a midline clival endoscopic view. You can get into the vitreous apex here, but maybe for cholesterol granuloma, but not for petroclival meningioma. This famous group of endoscopists, Charlie Tu, my friend from Australia, Amin Kassam, Schneiderman, Gardner, Yap, and Schwartz, and recently my friend Fred Gentili from Canada. Here we are in a tour in Sharm el-Sheikh. Look at this. Most recent studies on endoscopy and posterior fossa meningiomas are anatomical studies. Most. In the words of Karu, a famous endoscopist, restricted approach for the petroclival meningioma. It may be good for a small midline clival meningiomas. All cases reported are subtotal excision, are serious cysts, and serious reconstructions. Kassam would say use of endoscope is not superior to microscope in posterior fossa. But for the retrosigmoid approach is still controversial. Theodore Schwartz, placing an endoscope, inserting and withdrawing through cranial nerves in the posterior fossa is a blind process and carries high risk. Michael Gabb, the corridor between intended detrimatus and jugular foramen must not be entered by endoscope. So as I said, endoscopy is the future of neurosurgery, but for petroclival meningioma, it's still a long way to go. However, some people tried, Professor Karu tried this. Again, he would leave a good residual here. Endoscopic from Australia, again, leaving a very good residual. And from Turkey, the same, leaving a very good residual. So still, we have to push the envelope that far for this kind of tumors. Here, Marcos Tatajiva, who is trained with the Professor Sami and is holding his fortress now alone as a teacher of skull-base surgery, he used the endoscopy-assisted sigmoid approach, and he would show you these, showing the suprameatal tubercle. So when you drill it, you can use the endoscope to make sure that there is no tumor left there. Now to my series, and I hope I will finish quickly. Between January 90 and January 2018, I had 116 cases. I've been very lucky. Lots of cases are referred from the countries around Jordan. Jordan is a medical hub in the Middle East. So these are every single case that I dealt with over this period of time. However, 34 patients were lost, so I cannot include them. 116 operated upon, 34 lost, so I've been left with 82. And with the 82, some of them, they had given me short period of follow-up, so I don't include them. Only 54 had long period of follow-up. That's why I'm including this for you to see the good, really assessment of the surgical practice there. So these are the 54 cases of mine, which I'm reporting here. The tumor diameter is variable from 1 centimeter to 6.9 centimeter. Some of these cases, they are really giant ones. And the coronal view and in the sagittal view. However, not every case of lesion in the posterior fossa is a meningioma. The differential diagnosis is very, very wide. And here is again a question. Should we be doing radiosurgery without biopsy, or is it mandatory? I think we will leave this for discussion. But look at this very nice paper of the differential diagnosis in that area, looking at if it is extraaxial, intraaxial, intraventricular, in the skull base, high T1, low T1, and what exactly is the differential diagnosis. I will save you the trouble and show you that the common lesion is common. Petroclival meningioma or jugular foramen meningioma is one of the differential diagnoses. The second ones are schwannomas, being oculomotor or trochlear or trigeminal or abducent or vestibular. Schwannomas, vagus nerve, accessory nerve, hypoglossal nerve, these are my cases. A glioma presenting laterally like this, epidermoid, chondrosarcoma, giant cell tumor in the lymphatic sac, meningioblastoma, lipoma, gloma jugulare, metastasis, choroid plexus papilloma, neurosarcoidosis. And here again is a point where we may stop in our discussion of something like this being treated with radiation, what would happen? Chondrosarcoma, ependymoma, atypical ATRT, lateral medulloblastomas, DNET, cholesterol granuloma, cavernoma, vascular, gloma jugulare, and aneurysm of the vertebral or of the petrous carotid artery. Histiocytosis, they love that area. They love the petrous subclavian area like this, tuberculoma or lymphoma. Again, we have to think carefully. This is a very nice paper about Rosai-Dorfman disease from China, mimicking the very much like petroclival meningioma. So my series 54 patients, mostly females, and I looked at what Kawasi did. He classified his cases into 4 subtypes. He did not just put them together, lump sum. He said, well, we have 4 types of these petroclival meningioma. The upper clival, the cavernous type, the tentorial type, and the petrous ibex type. And I said, this is very good classification because really the relationship of the tumor with each of the cranial nerves is different in everyone. So this is the upper clival. Look at where the 3rd nerve, 6th nerve, 4th nerve, 5th, 7th, 8th, and the trigeminal. If you take the cavernous sinus, again, the relationship of these nerves would differ completely. Tentorial, same, differ. Petrous ibex, different. So I said, let me put my cases in the same way, and I classified them into upper clivus, the cavernous, the tentorial, and the petrous ibex. The commonest is the upper clivus, so this is the upper clivus. 20 cases, majority of my cases are upper clivus. The cavernous sinus, 15 cases. As I said, these are the cases with long follow-up. I'm talking about 10, 12 years of follow-up. Tentorial type, and I have 12 cases. And the petrous ibex type, and I have a good number of cases, but they are less than the other 7 cases. So I looked also into the images of this series of patients. CT scan is very important. It can show you calcification like this. Look at this. The MRI is very important, and the darker they are, the more fibrous and the tougher they are, because calcification would show darker in T2 signal. Is it unilateral or bilateral? In this case, I thought of sarcoidosis, but it was negative. It was bilateral petroclival meningioma. The size could be small, could be large, could be giant. I looked at the origin from the clivus. Are we dealing with the upper clival origin or mid-clival or total clival origin? I looked at the shape. Sometimes they just take this weird shape, very unusual shape. I looked at the cranial nerve foramina. Look at this. The tumor is going into the internal meatus jugular foramen and so on. Again, this is a very good landmark to know whether this tumor will come back or not. Is there a plane of the cleavage like this, or no plane of the cleavage like this? So I know here that the pia has been infiltrated and the brainstem is in direct contact with the tumor. Good plane of the cleavage, bad plane of the cleavage. Is there hydrocephalus or not? Is there any nodularity on the surface of the tumor? This maybe makes it a very tough tumor to deal with. So nodularity, lack of plane of the cleavage, brainstem edema, or are parameters of difficulty of these lesions. How much is the brainstem is compressed? Look at this here. Is there any brainstem edema, which is a bad sign of flex spinal invasion, as I said? And whether I can see the vessels inside the tumor, yes, here you can see the posterior cerebral is inside the tumor, and here, and here, and here the basilar. The MRA itself would give you a clue about the deviation of these vessels. It's very important, it's essential. Again, here you can see this tumor and you can see the deviation of the arteries, like this here. Same thing, the MRA will give you a clue. In the this particular patient, look at the tumor and look at where the basilar is pushed posteriorly. MRV is essential for me, and the most important thing is that if you are attempting the posterior fossa, that you see the occipital sinus. You may resort to doing conventional angiography for various reasons if you don't have enough information about the arterial relationship, the vascular relationship, so conventional angiogram is important. And these tumors usually are supplied by the ascending pharyngeal, by the tentorial artery, by the clival artery, the branches of the meningiohypophyseal artery. This is a case of mine where you can see the tentorial artery supplying this tumor, and here the ascending pharyngeal supplying this tumor. Venogram, again, look at this, occipital sinus, persistent occipital sinus. If you are unaware, patient will die on table if you are not aware of that. So I may use the embolization for these tumors. I don't usually use it frequently, but sometimes I do. In this case, I did look at this tentorial artery of Casinari supplying this tumor. And here you have to embolize the meningiohypophyseal artery, tentorial artery, the ascending pharyngeal artery to get some reduction of the blood supply, as we did in this case of mine, where we embolized the tumor pre-surgery. What are the presentation of these cases? Mostly they present with increased intracranial pressure, the paresis is common. The commonest is the cranial nerve deficits, and the commonest nerve in my series affected was the abducent nerve. I used the retrosigmoid in 41 cases, the PETROUS in 9 cases, the presigmoid in 4, and combined in 4. And whenever available and feasible, we do Karnofsky performance scale before and after surgery. I use the retrosigmoid in the semi-sitting position. I turn the head towards the lesion, like this. And I may use the navigation, but definitely I would use the cranial nerves monitoring. I achieved gross total resection in 38. As I said, gross total resection is Simpson grade 1 and 2. And I had recurrence in 2, near total resection in 9, I had recurrence in 4, and the subtotal resection in 7, and have recurrence in 4. As I said, follow-up, the minimum for me is 24 months. That's why I stopped at 2018. But the longest is 176 months. The morbidity in my cases, as you can see, motor weakness, ataxia, temporal infarct, CSF leak, hydrocephalus, pneumonia, but the commonest is the new cranial nerve deficits. And again, the commonest new cranial nerve deficit is the abducent. Surgical results were good in 38, fair in 10, and poor in 4, and I've lost 2 patients. Out of the 84 in which we had at least a short follow-up on them. Histopathology types, 21 were transitional, but I had one unique case of melanocytic, which was extremely malignant. So we started like this, I went in terional approach, excised it, it came back, and then it flared up in a very big way within 6 months. Very malignant melanocytic histological subtype. In the same period where we did this primary surgery in those long followed-up cases, the 54 ones, at the same time we performed primary gamma knife in 9 and secondary gamma knife in 11. So in my department, the gamma knife is complementing the surgery, and surgery is complementing the gamma knife. Now these are the cases that we have treated either because of upfront, not before surgery, upfront treatment, old age, medically unstable, or if the patient does not even want to think about surgery. One of the cases, and I have covered the patient's name, but this is my name as the operator for this particular tumor. Also this one, this 45-year-old male came with this tumor, upper clival going into the cavernous sinus. I went in and removed except for the one which is really inside the cavernous sinus, and we gave gamma knife for that. This patient had 4 surgeries before he came to me, and then you can see the surgical changes with this tumor. He was referred for gamma knife. It was really brainstem severely compressed, and the size is very big. I went in and did a partial resection, and this remnant was given gamma knife. Some of the illustrative cases quickly. A 40-year-old female patient with this tumor before and after surgery. Again, this is going into the Nichols cave, but completely removed. This lady with this very difficult tumor with nodularity, with brainstem edema, with no plane of cleavage. I really did not want to operate upon her, but I had to because I was forced to. And we did the surgery for her, and she came out with a drift of her right arm, but generally well. And then she recovered completely within 2 months. There was no recurrence, but then we found this spot here. We are being following it now for 10 years without any change. So we did not jump into gamma knife immediately. This tumor again, before and after surgery. Same thing here, this female patient, 32, with this very formidable lesion before and after surgery. This lady from Syria with this tumor before and after, and the long follow-up for this case without recurrence. This patient, 57-year-old female patient with this tumor before and after. 57-year-old patient again with this tumor before and after. This patient had surgery before, but surgery was a real failure. They just managed to take part of the cerebellum out without touching the tumor. And she was referred to us for gamma knife, which is usually the case. They failed the surgery. They said gamma knife is the washing machine to wash their mistakes. It's not. It should be done in a very good fashion. This is not good for gamma knife. Severe brain compression, very huge size. You must go in and take it out, in spite of the previous adhesions from previous surgery. Again, this patient with this large tumor for and after surgery. This patient from Sudan with this tumor, and this patient from United Arab Emirates. So, steps of surgery in a quick fashion. This is the view from the lateral sigmoid approach, and this is at the end, where you can see the facial, the trigeminal, and you can see the lower cranial nerves. You can see the abducent nerve. And this particular lady with this tumor retrograde, and you can see the facial nerve and the ICA. And then here we are seeing the tumor entering into the cavernous sinus, working between the trigeminal and the facial. And here is the view from the visceral fossa. This is the dorsum celli, and you can see the third nerve arching going into the cavernous sinus, the facial nerve, and the lower cranial nerves also. Quick views of the videos, and then we'll be done. This is the pre-sigmoid approach here. This is the middle fossa, and this is the posterior fossa. This is the facial vertical part of the facial nerve. Osteoid is ingelled. So this is the bone overlying the dura of the middle fossa. You remove it, you thin it out, and remove it completely, preserving the sigmoid sinus here. So you thin out the bone before you attempt to remove it. This is a subtemporal intradural approach where the tumor was really, and this is the lady with the lots of nodularity and edema of the brainstem. So here I'm trying to find a plane of cleavage between the tumor and the tissues of the brainstem using the ultrasonic aspirator to remove. Here you can see the tumor here is attached to the posterior and superior cerebral and superior cerebellar artery. You can see me here trying to find the plane of cleavage between the tumor and the artery. This is a posterior view, and you can see that the tumor has been separated from the facial nerve, and here is the tent. We will attempt to remove the tumor completely. So this is the tracheal nerve. We have opened the tent. Actually, we are cutting the tent so that any tumor attached to it will be removed. And this is the third nerve, the basilar artery, and so on. And this is the view at the end of the surgery. The trigeminal, the facial, the ICA, the lower cranial nerves, and the abducent. That's the abducent. Here I'm showing you the vein of Dandy, the trigeminal nerve, and how to preserve it in the sitting position. I love the sitting position. It's one of my favorites. But look at here, you have preserved this vein, and here we're going into Meckel's cave. Here we're going down, and we are separating the pica of the tumor. It's going like this. We're trying to find the plane of cleavage. And here, taking it off the brainstem, using the ultrasonic aspirator. And don't touch things here. We have the pica. As I said, they extend down, they extend medially, they extend up, and you have to follow them. This here is taking it from the accessory nerve. Here we are separating it from the vertebral artery. Again, here showing you the vein of Dandy being preserved, going into the superior petrosal sinus, and there is the trigeminal nerve and Meckel's cave. In this case, in the semi-sitting position, the facial nerve here, and then working in between the nerves, working between the trigeminal and the facial, the trigeminal and the tent, and so on. So this trigeminal and this is facial, and I'm working in between them. The tumor is very vascular indeed, but in the sitting position you don't bother because the CSF and blood would just flow down. Here I found the origin of the tumor. It's from the back of the dorsum celli, from the seroclinoid. I'm keeping this for people to see the amount of bleeding that is just flowing down, not causing me any problem. And I can see here the third nerve going into the oculomotor triangle here. Then I'm separating the tumor from the underbelly of the third nerve, this way from the midbrain and pons. So this is the third nerve. Again, here working in between. I'm looking here for the abducent. It must be here. And every small arachnoid you leave would be beneficial. Here I'm finding that this is the sick nerve. So it really is very tiny stretched nerve. But because I know where to find it, then it's easy. So it's basically working between the nerves and the semi-sitting position and working there would give you the opportunity to remove the tumor completely. So this is the view. Dorsum celli, this is the vertebral stalk, this is precom, third nerve going into the oculomotor triangle. Beautiful view that you can see from the posterior fossa approach. With this, I finish, and I thank you for being patient with me. I think Let's stop here. We are open for any questions or comments.
Very good. Excellent, Dr. Sabea. Okay, the panel it's open for questions for Dr. Sabea.
Or maybe we can ask Professor Osman to present his radiosurgery part, and then we can take the questions. Maybe this is
Okay,
better.
whatever you want to do, Doc.
Yeah. Professor Osman, would you like to start your presentation?
Yes, sir, certainly.
Thank you. Go ahead.
I think I'm sharing the view now.
Yeah,
Yeah.
perfect, perfect.
Thank you. After Professor Space's exceptionally difficult cases and beautiful surgery, I would like to share with you my take on the gamma knife surgery for petroclival meningiomas. As we have mentioned in the presentations before, the meningioma gamma knife started in 1970s with the pioneership of Professor Steiner, who was one of the leading figures throughout his life, being both a very good surgeon, very capable surgeon, and also a very capable gamma knife radiosurgeon. And then the gamma knife machines came to Middle East with the help of Professor Sbeig and Professor Pamir, my chairman. And since 1997, we have a gamma knife unit in Turkey. And throughout this period, there have been many changes to the technology and to the capability of the gamma knife machines. We have started these treatments at Marmara University, and after having treated over like almost 10,000 cases at that center, we have switched to a new university, Acıbadem University, and since 2006, we have accumulated over 8,000 cases at this institution also. And from these, we have learned that not all meningiomas are the same. Two presentations before, we have talked about parasagittal and Falx meningiomas, which are a really difficult tumor to treat, both surgically and both using gamma knife treatment. But over the years, many centers have gathered very much information about the treatment of meningiomas, and the general consensus today is that skull-based meningiomas fare much better from gamma knife treatment when compared to convexity or parasagittal meningiomas. And petroclival meningiomas are not an exception to the skull-based cases. Most of these cases fare quite reasonably after gamma knife treatments, either primarily or as an adjunct to surgical treatment. But as a prerequisite, I wish to say that the cases that are selected for gamma knife treatment are selected cases. Therefore, we have a certain selection bias in the treatment of these lesions. And again, the cases that cannot be treated by a gamma knife and that are referred primarily for surgical treatment are the most complex and the more complicated cases, which make the life for skull-based surgeons much more difficult for the treatment of these cases. But again, when you look at the percentage of atypical or anaplastic meningiomas, you're seeing that the parasagittal meningiomas or convexity meningiomas or the sphenoid wing meningiomas have a very high percentage of atypical or anaplastic meningiomas, the ones with a more aggressive tumor biology. But compared to those, skull-based meningiomas have a far less percentage of cases that are more aggressive. This makes the life also easier for treatment in the skull base. Again, over the years, we have learned that petroclival meningiomas generally tend to fare well from gamma knife treatments. as in these examples that you're seeing here that have not changed in volume or slightly decreased in the volume after gamma knife treatment several years after the treatments. Therefore, I wish not to go into more details about why we do gamma knife treatment or how do we select cases, but try to learn a little more about biology or the anatomy of these cases from the cases that we have treated in using the gamma knife treatment. So this brings us to the definition of a petroclival meningioma. The definition of a petroclival meningioma is kind of complicated, just as Professor Svej has very elegantly described in his presentation. We know that these do not make a large proportion, but only a minority of the intracranial meningiomas. And since the time of Cushing, they have been a difficult tumor type, a meningioma type to treat. In the 1950s, Castellano and Ruggiero tried to classify posterior fossa meningiomas into different subtypes. And shortly after this, Yaşargil also presented his take on these posterior fossa meningiomas, and actually came for the first time came up with the definition of a sphenopetroclival meningioma. A petroclival meningioma that extends into the sphenoid wing also. These were the most formidable, most complicated cases of his time. He described the growth routes and growth origins of these meningiomas, and described that petroclival meningiomas actually originate at a very small portion of the petroclival junction, just anterior to the trigeminal nerve, but they tended to grow and invade the surrounding areas over time. But the exact origin was not described in his very detailed description of these cases. He somehow left this area open, which was the work, which was filled by the work of the master skull-base surgeons. And El-Mefti actually defined a petroclival meningioma as those arising from the spheno-occipital synchondrosis with the epicenter of the tumor located in the upper 2/3 of the clivus, medial to the cranial nerve 5, medial to the trigeminal nerve. But this actually leaves a very large area although it's very small area, it's a very large area for variation of these very versatile, very variable tumor type. In his review of this of petroclival meningiomas in the 2010 meningiomas book, El-Mefti again emphasized that the exact origin of the tumor is exceptionally important, just like we have heard from Professor Svej's presentation just now. Because the origin dictates the arachnoid planes between the tumor and the brainstem that we have to protect. So many meningioma types in this very small area also can mimic petroclival meningiomas, just like the foramen magnum meningiomas, which are located lower below, lower in the lower one third of the clivus, either centrally or paramedian location. As we have heard from Professor Svej's presentation, Professor Kavase brought a very interesting look into the origin of these meningiomas, which arise maybe even millimeters away from each other, but can present with very different surgical problems in front of you, because they meningiomas, based on their origin, tend to displace the cranial nerves and the brainstem in different fashions based on their location. Kavase described 4 different types: the upper clivus type, the cavernous type, the tentorial type, and the Petrous apex type. These were actually, again, as you're seeing on this graphic, only located very mildly away from each other in terms of their origin. Again, in the 2010 review, Al-Mefti described 5 different types into meningioma classification. But for a beginner, actually, Professor Kavase's classification into 4 types is slightly more intuitive. And finally, last year, in a presentation in Turkey, Professor Ali Krisht, actually, who has worked with Professor Al-Mefti and Professor Yaşargil for a very long time, gave a very interesting view into the life of these, into the natural course of these meningiomas. He clearly mentioned that the sphenopetroclival meningiomas are actually, in fact, cavernous sinus meningiomas and arise posterolaterally, infralaterally to the trochlear nerve within the cavernous sinus, and that most of these patients extend along the tentorial edge, like invading the tentorium and giving an invasive front along the tentorium. So I wish to give you a few examples and discuss the origin of these meningiomas based on the sphenopetroclival, actually, meningioma, basically located within the cavernous sinus and extending into the posterior fossa along the tentorium, just as Professor Krisht has explained. This is maybe called a cavernous sinus meningioma, maybe called a petroclival meningioma, even maybe called a sphenopetroclival meningioma with its extension into the beginnings of the very medial part of the sphenoid wing. And then you're seeing a smaller example, again located within the cavernous sinus, again extending into the petroclival area, but this time extending lower into the clivus with a very small sheath-like growth over the clivus. Again, here you're seeing another example with similar growth characteristics, but growing this time more into the sella turcica and more into the anterior part towards the sphenoid wing. But as you can clearly distinct from the sagittal views, as you're seeing here, this tumor causes hyperostosis in the anteroclinal process, and most likely is a clinocavernous meningioma that extends into the petroclival area and into the tentorium as a secondarily after this initial growth within the cavernous sinus. As you're seeing from these very few examples, even within the cavernous sinus, these tumors tend to have a very variable course and very variable extension. These are not stereotypical tumors, and every single one of them comes with a different history and comes with a new difficulty, just like we have seen from Professor Svei's presentation. Again, here you're seeing a tumor that grows primarily into the starting from the cavernous sinus, starts to grow into the middle fossa towards the temporal lobe. Then we have another type of petroclival meningiomas that origin posterior to the trigeminal pore, but these can be located laterally, medially, superior or inferior, located in relation to the trigeminal pore. But these are somehow classified according to their invasive potential into the trigeminal cavity. Here you're seeing a larger tumor that was treated and that's extending, starting from the lateral portion of the trigeminal pore and has grown over many years. This case was referred to for the gamma knife treatment because he was denied surgery by many experienced neurosurgeons, and finally we started a gamma knife treatment on this patient. And on the images down below, you're seeing that we have somehow managed slight volume reduction with alleviation of some of the symptoms that this patient had. Again, you're seeing another complicated case, invading both here, as you can see on the T2 weighted images, both the cavernous sinus and the Meckel's cavity, and extending into the petroclival area with a nice plane between the tumor and the brainstem. But because it was invading the cavernous sinus portion, cavernous sinus, surgical removal was not attempted, but was primarily treated with gamma knife. And as you're seeing on the lower row of images, that this tumor has responded by not growing over the years to the gamma knife treatment. Here you're seeing another example, which has its origin from the lateral portion of the trigeminal pore and has grows into the Meckel's cavity and extending into the cerebral point, into the petroclival area. Again, here another slightly large or middle-sized tumor with some compression of the brainstem also, which has responded nicely to the gamma knife treatment. Again, I wish to emphasize that we do not treat all like mid-sized tumors like this one in the same fashion. Most of the times, these tumors are considered very strongly for surgical treatment, but because of one or the other reason, these were treated with gamma knife treatment. Again, here you're seeing an example that has grown from the inferior portion of the trigeminal pore, and it's grown primarily into the Meckel's cavity again. I put on these all of these images to show you the strong variability among the tumors of this region. These do not follow one single rule and are not located at one single area. These are petroclival meningiomas are very variable tumors. Again, here you're seeing another meningioma located in the petroclival area with the origin located below the trigeminal pore, above the jugular foramen. And again, another example, as you're seeing the origin of the, on the T2 images, T2 weighted images, the origin is located anterior to the internal acoustic canal, below the trigeminal pore, with the origin below the trigeminal pore and extending into the trigeminal cavity. There may be some meningiomas located in the region, but those are not petroclival meningiomas. I wish also to give some examples to those. Here you're seeing an example, and a tumor that's located posterior to the posterior to the internal acoustic canal, which makes it simply and cerebellopontine angle meningioma by definition. Again, you're seeing another tumor located in the lower 1/3 of the clivus, which makes it into a foramen magnum meningioma. Again, another example here with the tumor extending into the jugular foramen and also into the internal acoustic canal, which makes, in our definitions, it into jugular foramen meningioma. And as you're seeing, we don't treat always very easy cases after discussions, and failures and complications are, despite the complexity of these tumors, somehow rare, because again, the tumors, the petroclival meningiomas, are mostly benign tumors with a benign course. And again, we always introduce a selection bias into the treatment of these cases. But again, as you're seeing on this example here, this lady who was not treated with surgery, but was treated in the beginning satisfactorily with gamma knife treatment, started having a recurrence in the middle fossa 4 years after the initial gamma knife treatment, after actually a successful gamma knife treatment with significant volume reduction. And also you get side effects related to the to gamma knife treatment sometimes. Here you're seeing a tumor that was treated in the cerebellopontine angle, at the petroclival region, with significant brainstem edema, but which resolved nicely after steroid treatments after only one single month. Finally, coming to the conclusions, I wish to emphasize that the definition of the petroclival meningiomas is that they arise from the petroclival junction anterior to the medial to the anterior and medial to the trigeminal nerve, but their presentation and extension varies considerably among all cases. Surgical resection remains the gold standard of treatment. However, at the risk of significant morbidity, of cranial nerve morbidity or brainstem morbidity in these patients. Therefore, gamma knife treatment provides an option for recurrent cases, residual tumors, or small or medium-sized tumors with progressive growth, if they are not amenable to surgical resection. So thank you very much for your attention and for your patience. And with this, I wish to give the word to Professor Sbeik again.
Thank you, Professor Harteman. Very elegantly described. And it just complements that's what I've said earlier on, that there is no fight between microsurgery and radiosurgery. They complement each other. Each has its own indications, advantages, and disadvantages. But the irony that if the gamma knife falls in the hands of a mediocre surgeon, he will be treating everything with gamma knife. And if he's just doing gamma knife, surgery would not be done at all. So it should be in the hands of microneurosurgeon and radiosurgeon in the same department, with a committee to receive the cases, select them for the proper treatment. Thank you very much again, Professor Harteman. And the floor is open for any questions or comments. John?
Hi from Amman, Dr. Sami Khatib with you.
Hello, Sami.
Thank you, Dr. Sbeik, for the excellent lecture as usual. Just I would like to ask my colleague from Turkey 2 or 3 short questions. First one, what's the inclusion criteria for the treatment for such tumors? The second one, if all these tumors were diagnosed by biopsy. And the third one, if this treatment is covered by the government in Turkey. Thank you.
If I may, Professor Sbeik, we have a clinic that has a very aggressive approach to almost all tumor cases. But nevertheless, over the years, we have learned with difficulty that petroclival meningiomas are very, very difficult tumors in some cases, especially those that do not have a plane between the tumor and the brainstem. And in those cases, we try first of all to use gamma knife as a treatment for these cases, basically to avoid the significant cranial nerve and the brainstem morbidity that we might cause. But in patients that have a significant brainstem compression, sometimes there's no other option rather than except for the for surgical resection of these cases. But these are not daily easy cases. So therefore, we sit down together as the whole department with Professor Pamir and other senior surgeons, also introducing their comments into the treatment, and decide together what to do for those cases. The treatment for the gamma knife treatment for any meningioma is covered by the Turkish government, and therefore this is not a limitation for the treatment. And
biopsy. The question about biopsy. Do you need to take a biopsy before treatment?
Biopsy, most of the times we do a detailed MRI, and in today's technology, cases that are in which we are very confident that the lesion that we are treating is a meningiomas, we do not do a biopsy for these lesions. Neither do we do for cavernous sinus lesions.
I may like to add, Corey, that what you said about a committee of neurosurgeons and radiosurgeons, the whole department in your hospital would sit together and decide whether this case should go for radiosurgery or for surgery or combination of both. That is my message, that if the gamma knife falls into the hands of one person without any committee to supervise or to choose the cases, then this person would treat everything across the table with the gamma knife, and this is wrong. So this is the message. Whenever you have a gamma knife, you must establish a committee made of prominent surgeons and radiotherapists to choose the cases. Am I not right?
I completely agree with you.
Thank you.
Yeah, I agree 100% with you, Dr. Sbeh, and this is the best way working teamwork. So they should give the kind of tumors.
Dr. Sami Al-Khatib is a senior radiation oncologist in Jordan, and he shares very good ideas with me about the way to treat these cases. Thank you, Sami, for participating.
Thank you. Thank you.
John?
Mahmoud Nassar has a question. Go ahead, Mahmoud.
Hello, I'm Dr.
Yes.
Mahmoud Nisa from Jordan. I want to ask Dr. Osdom question, please.
Sure.
Dr. Osdom, you have seen us. You have showed us so many cases that were petroclival meningiomas that treated by gamma knife. Even it is associated with brainstem compression, pons compression, pontine compression, midbrain compression. I think the gamma knife will take 3 to 6 months to start working, and the tumor even may not shrink, may stay in the same size. What about the brainstem compression for these cases? I think it is against the rules for the use of gamma knife radiosurgery.
I think the rules that you wish to put on are not easily applied in the case of petroclival meningiomas. In petroclival meningiomas are very heterogeneous group of tumors because of their origin, because of their compression, because of their clinical findings. And just like Professor Sbeh has underlined, and as I also have underlined, this must be the decision how to treat and when to treat must be taken by a group rather than treating everything according to the book. This is what I think.
Okay, yes, I'm with this talk. Thank you.
My pleasure.
Good evening, sir. Good evening, Prof. Sbeh. Good evening, Dr. Osman. And thank you so much for the great presentations and the invaluable information you keep sharing with us. May I have questions for Prof. Sbeh, sir? Yeah, well, my question is, do you think that there is a significant effect on radiosurgery for patients who came to you after a session of radiosurgery?
Excuse me, I'll get that. I'm sorry.
Okay.
Okay.
So the
So
question was, yeah, I got your question, Juan. The question is there any difficulty operating on cases that had radiosurgery before?
Exactly. Right.
And the straight answer to this is very much yes. Surgery after radiation, whatever kind of radiation, whether radiotherapy, conformal radiotherapy, or radiosurgery, is definitely harder than doing a case as a virgin case. So yes, and here is the question that we've been debating about, that the decision to do something for a patient should not be a single person decision. It should be the decision of a committee of senior people, senior neurosurgeons, senior radiotherapists, senior oncologists, senior endocrinologists. Suppose that you are giving us a case of pituitary tumor. What should we do? Should we do surgery? If we do the surgery transnasally or cranially, should we give radiotherapy or radiosurgery? What are the investigations to be done? So a committee meeting on a weekly basis, and I trained at Karolinska Institute in Sweden. We stayed there for 6 months. Every week we had sessions from the morning 8 o'clock till 8 o'clock in the evening to discuss the cases referred to Karolinska for treatment. So if it is a pituitary, the endocrinologist should tell us and guide us what to do. And the oncologist, the radiation oncologist, the radiation people concerned. So again, if the decision of the committee is to go for radiation, for radiosurgery, then that is the decision we have to accept. This is for the best of the patient. And if the tumor recurred again, I have to operate. I know I am gonna face some difficulty. But again, the decision in the first place was taken by a committee. And in the first place, this was the best decision for that particular patient.
Okay, thank you, sir. And that difficulties would be in more bleeding, and the tumor would be, the tumor would be more fibrous, or?
Sure, the answer is yes. If you had radiation, then difficulties as such. The possibility of identification of the color of the structures would vary. You would lose this ability to define this is a nerve tissue, this is an artery.
Okay.
There will be lots of adhesions between, or the interface between the tumor and the brainstem. Also, the vessels will be friable. Also, the cranial nerves would be more amenable for injury of the traction more than the usual. So, no doubt, all the papers published, especially those published by the giant of CT angle surgery, was Professor Sami, Majid Sami in Germany, in Hanover. He would tell you straightforward that all the cases he's done, and he's done a lot. He's done 5,000 cases of vestibular schwannomas. All the cases referred to him after gamma knife were more difficult. Again, I refer to this paper in the States. I can't remember the name of the author, but they were questioning, I think it's from Mayo Clinic, does your practice of surgery or radiosurgery differ according to where you live? And the answer is yes, even in the States. Different states, they have different approach for these tumors. Imagine a country, a third world country or underdeveloped country having a vestibular schwannoma. What can they do? They are not experienced in surgery and they don't have a gamma knife. So it's a lot of philosophy here involved. But at the end of the day, whatever we would do, whatever we decide, it has to be decided for the benefit of the patient, not for the benefit of our pockets.
Okay. Thank you, sir. Thank you very much.
More comments, questions?
Hello, can I ask a question?
Of course.
I'm Dr. Najjar from Syria. Thank you very much for your nice presentation, Dr. Sbeh, and our friend from Turkey, from Acıbadem. Actually, I have two questions. The first for Dr. Sbeh. What your advice in your experience to control the feeding artery of the tumor for early devascularization for the tumor if you use a retrosigmoid approach? Do you use supracellular infratentorial as Otel Goal in his article to control the feeding arteries? The second question is for our friend from Acıbadem University. I noticed that the tumor is larger than 3 centimeters, which is the limit of the gamma knife. So do you think that cyber knife can be more effective for such tumors? Thank you very much.
Okay, Jalal. Jalal is a close friend of mine. He's a senior Syrian neurosurgeon who has my respect and admiration. He's basically a macrosurgeon and endoscopist. So Jalal, thank you for participating. And your question was about the bleeding to control or to minimize the bleeding in the PETROUS approach. I think PETROUS approach has lots of advantages. First of all, you don't have to go for the PETROUS work, drilling of the bone, and you know, coming across the sinuses and things like that. But the most important thing is that directly after you open the dura, you are on the tumor, you are on the PETROUS bone, so you can really minimize the amount of bleeding. I have shown in my video that I went into the dorsum celli, to the posterior clinoid, and there was the bleeding coming from, because I know the clival branches of the catenary and the vessels there, they are supplying the tumor. So I went there to minimize the bleeding. So yes, retrograde, whether you go supracerebellar, infratentorial, or whether you go lateral, just the same, you are on the tumor, on the spot directly, and you can control the bleeding. Leave the next question to Professor Osterman regarding the size of the tumor and whether CyberKnife would be better to use.
Okay. Gamma knife was first invented as a neurosurgical tool, in 1968. This was over 50 years ago. In those days, there were only two extremes. One was the gamma knife treatment, which was delivering the radiation just to the anatomically very strictly defined target, or the radiation therapy, which was delivering radiation in fractions with less that of a targeting. Over the years, these two extremes have learned from each other. The machines, the radiation oncology, radiotherapy machines became more capable of targeting lesions more accurately inside the brain. And over generations, the gamma knife machines started doing fractionation, becoming closer to what the radiation oncology machines were making. But down below, down to the bottom, the ideology of how to use and how to do the radiation delivery between these two types of treatments still are different. Gamma knife machines still is basically aimed at targeting, and the radiosurgical alternatives, stereotactic radiosurgical alternatives, such as CyberKnife or true beam treatments, are more aimed at fractionation and protecting the tissues biologically rather than very strict targeting. So this is why when you're dealing with a lesion that's small or that must be very strictly targeted, you use gamma knife. But most of the centers, most of the large centers have both machines. And when you're dealing with larger tumors, when you have to protect the surrounding tissues, you tend to switch to the radiosurgical alternatives of CyberKnife or TrueBeam. But in the end, if one center has either of these machines, both can be, both techniques like gamma knife or other radiosurgical techniques can be used interchangeably. I hope this answers the question.
Of course, of course. Thank you very much. Thank you.
Thank you, Dr. Najjar.
Thank you. Take care.
John? John, are you there?
John muted.
I'm sorry, I muted myself. Okay, more questions, comments, please?
Yes, I have one, John.
Hey, Marco, how you doing?
Fine. First of all, thank you for your wonderful presentation, Dr. Zbai and Dr. Ostman. They're very great about that topic, as it's very complex, like PETROUS meningioma. My question is maybe a little bit extreme. I saw in your cases some PETROUS meningioma are able to cross the midline in this case, you're able to remove a gross total removal in just one surgery, or you consider a second surgery on the contralateral side, or you move the patients to Dr. Korai for a gamma knife?
Thank you very much indeed. So your question is pertaining to those petroclival meningiomas crossing the midline, approaching the midline, and crossing to the other side. What should one do? Can one remove them in one session, or does one need to do more than one session? The answer is yes. If the patient needs another session, I don't have any hesitation. I may go posterior fossa first, and then I may go pre-sigmoid, I may go terional, whatever. So I don't have any hesitation in doing it in 2 stages, but I prefer to do it in 1 stage if I can. And to my surprise, always when I think that this part of the tumor is difficult to remove, once you remove the main bulk of the tumor, you will find a space to follow that across the midline. So the tumor would give you the dissection. The tumor would help you in doing the surgery. But I have no hesitation. If the patient needs 2 stages, I would do that. If the patients need a gamma knife afterwards, I don't have any hesitation. I consider gamma knife as a good tool, but it should be in the hands of good people, not in the hands of fools. Because a tool in the hands of a fool is still a tool.
Thank you very much.
Well, let me just mention that Marco is a neurosurgeon from Northern Italy that has an interest in peripheral nerve injuries. He's going to do a series of webcasts shortly. So stay tuned. Okay, more questions or comments from the panelists?
I have a question for Professor Sbey. Sure. Especially about the most difficult cases. Probably these the ones that do not have a plane between the tumor and the brainstem are the most complicated cases. What are your techniques, and what is your approach to dissect those tumors from the brainstem? Do you have any special tricks or that you apply in those cases, or anything that needs to be done differently?
I have shown one case, and I described it as the most difficult. It was a large petroclival. You have seen the nodullarity. It was irregular in shape. It was really inside the midbrain and the pons. And really, I did not want to operate on this lady because she had all the features of a bad case. The multinodularity, hard tumor, it is inside the midbrain, no plane of a cleavage. I tried really to escape the surgery, but I was really forced to go in. Now, when I decide to go in for a case, I'm going in for a kill. I'm going in for a radical excision. But at the same time, I'm not going to do radical excision on the expense of the patient. But this is my intention, and I really geared myself, increased my adrenaline surge, and I imagine this tumor as an enemy of mine, and I just tried it, and I cursed it, and in a loud voice in the theater. My people around me would say, "You are fighting the tumor as a human being." And I said, yes, because I want to create this hate between me and the tumor. My aim is to remove it completely, but not at any expense. I would stop if I can't find the plane of the cleavage. If I'm trying to peel the tumor off the basilar or peel the tumor from inside the midbrain and I cannot find the plane of the cleavage, I stop, I raise the flag. But I'm against those people who decide beforehand, up front, that I'm going to go in and take a small piece of the tumor and send for the therapy. This is against my philosophy. This is against my practice in a complete fashion. So there are no tricks. I just keep at it with all determination to remove it. If I can, I'm happy. If I can't, I stop.
Very good. Okay, more comments or questions before we close? Okay, I'd like to thank Dr. Ozduman and Dr. Sabea. So any topic for next week, Doctor?
Yeah, we just agreed with Professor Ozduman that we will just change gears. We're thinking of doing foramen magnum meningiomas, but now we settled to do the craniopharyngiomas. Craniopharyngiomas, again, microsurgery or radiosurgery, and what comes in between. So next week, craniopharyngioma, microsurgery, and radiosurgery.
Very good. Thank you very much, and thank all the panelists for coming. And we'll see you next week. Thank you.
Thank you very much. Bye-bye.
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 Okay, we stopped recording. Yeah, it went well, Dr. Sabeh. I muted myself. I'm gonna fire myself.
You're okay. You're okay.
It went well. It went well.
Yeah, thank you very much indeed.
Yeah, I know you like Yuha is giving a presentation tomorrow and Friday too.
Yeah, super.
But you'll see it. You'll see it.
I will. Thank you very much indeed. Bye-bye.
Okay. See you next week.
Bye-bye.
So Marco, you like the plug I gave you?
Sorry, can you play?
Yeah, it's like television. You know, if I go on the show, I got to mention what I'm doing. You know, like late night television.
Right.
Yeah, but it's going well. And Yuha, you know, Yuha likes this. He likes doing webinars. And he's even helping us organize them. So, and like, if you get an invitation from him to speak, it's, you know, what are you going to say?
He absolutely exploited your knowledge in a very extreme way, right?
Yeah, but it's good. It's good. It's going well, and he's reaching a lot of Chinese neurosurgeons, which he wanted to do. That's one of the reasons why I think he went there, was to educate Chinese neurosurgery surgeons, but he was having a hard time because, you know, the language barrier, it's not like Italian, Spanish, English. Chinese is totally different.
Mandarin is totally different. The alphabet, yeah,
and it's English is not well known in China like it is in Italy and everywhere else. It's well known, but not in China.
Yeah,
but
even
now
the accent, the English spoken by Chinese people is sometimes, I don't know your mother language, you can tell me, but sometimes the Chinese talking in English language is not so understandable, right?
Yeah, it's definitely a problem. But Ben Zhu, he's translating for in Yuha in real time. In other words, he's giving Yuha's giving the presentation, and he's where you are translating it into another program to the Chinese neurosurgery group. And they had 30,000 one week. I don't know how many of them are neurosurgeons, but probably a lot of them were.
Yeah.
But yeah, translating it to Chinese makes a big difference. And they're doing it tomorrow at University of Miami. They're kind of borrowing our idea and having Ben and Yuha speak tomorrow. And you'll get a note. You'll see it because you probably get a lot of notices from me, right?
Yeah.
You probably get a lot of advertisements from me, right? Emails and stuff.
I think so. Yeah.
Yeah, I think you'll see it on Facebook.
Okay.
So how are things going over there?
Oh, well, here about the COVID, they are going well enough. There are some new cases. We got a curve in down, definitely in down, but now is increasing a little bit. Anyway, it has done avoid to reopen the school eventually. We were 4 months with closed school.
Yeah, you know, I think in this country, some places are opening schools, which I think is a mistake. But it's not going to last. It's not going to, because just if a few children get sick, every mother will keep her child home. So I don't think it's going to work. So.
Yeah, absolutely. You just need to open school with the right security in a right security way. So keeping the distance between alums, using the mask. We're attempting to do that. Nothing is perfect, but there's a good perspective for the future to have a reopening the school.
Yeah.
So is this about
well,
me? None of the. I was just telling that you have not seen me throughout these months because I was very busy. I was 2 weeks as acting head chief department.
Oh, good.
Yeah, because my chief department was in holiday, and so for 2 weeks I was the chief director.
Oh, you had to run the ship.
Yeah.
You had to steer. You're up on the top of the ship steering.
Yeah, correct. Yeah.
And you got to keep that ship on course, right?
King of the world. Yeah, right.
Not like that Italian captain. Remember, he ran the boat up into the. Remember that
Right.
Italian captain that the boat ran into the city or something.
Yeah.
That was crazy. So
Yeah.
no,
absolutely.
it's going good. Let's see. We have a big one this weekend on endoscopic spine. I don't know if you're interested in that.
Well, it sounds interesting.
Yeah, Friday and Saturday at Italy time. I don't know. Let's see. It'll be 11 o'clock in the morning. Probably pretty. Well, you'll see it. You'll see it on the Facebook. Yeah, 2 days. 2 days. Endoscopic spine.
Good.
And then we always have Sunday. Okay, very good, Marco. It's good to see you.
Good to see you
And
too.
you know what, Marco, I've discovered because I'm learning. I'm like a resident.
Yeah.
I'm like a resident in video. I'm in my residency. But one thing I'm learning is that if we set up your series of webcasts, that we make people register. It's a lot better because it looks better, if they can register, and I can easily set that up. So that way people will feel that, that's special. It's not going to cost anything, but it'll be just, they'll have to register to come.
To avoid, you mean, 100 and 100 of panelists. You mean so?
Yeah, well, I don't think we'll get. Yeah, I don't know. I don't know. We're trying different things. We're trying different things, and we're learning. But it's. I think the community will appreciate peripheral nerve. Someone doing it.
I'm completely available for this experiment. So just let's do it.
Yeah. Well, experiment for me too. I'm kind of learning.
Yeah.
So,
you're growing up with Zoom and with Neurosurgical Review by this experiment. So
yeah, but little by little, because I can see, Marco, a lot of institutions and neurosurgery programs, they don't have experience doing this, and of course they're not doing the right things. So I'm helping some of them along, like Morocco, Miami, just pointing them in the right direction to save them time. And it helps in relations too. If they want to do a webinar, they ask me to help them do the webinar. So but a lot of like Bangladesh, the national neurosurgery society asked me to set up their YouTube channel and stuff like that, which is easy, but it's a step that these school and universities and institutions have to do, is set up a YouTube channel so they can go on the internet. But they'll learn that after internship. So, okay, Marco, have a good one.
Have you too, John. See you soon.
Okay, we'll be talking. Okay.
Of course. Okay, I tell you about the date for the next webinar about peripheral nerve. I almost complete. You just need.
Yeah, no hurry. No hurry. No hurry. Okay. Bye bye.
Bye bye.